Hello, my name is Susan Leininger, and I'm an advanced practice nurse at Allegheny General Hospital in Pittsburgh, Pennsylvania. My topic to cover with you today is using an institute model to reduce the incidence of venous thromboembolism, or VTE, within a large hospital system. This is where I work every day. I'm part of the Allegheny Health Network, which is a large group of hospitals, about 8 in our network, and we are one of the largest hospitals with approximately 500 beds. We are a tertiary care center with a level 1 trauma and several different specialties that excel in the care of patients, those including neurosurgery, oncology, orthopedics, and cardiac surgery, to name a few. So what we did at the Allegheny Health Network level is that they developed an institute model to look at different quality features. So you can see from anesthesia from one corner to women's and children's health in the other corner. So there are 9 different institutes, and today I'm going to focus on the Orthopedic Institute. The goals of the individual institutes is, number 1, to collaborate to improve patient care, and to work with related hospitals and departments working within that care of that patient. So it's a sharing of ideas, it's a coming together of ideas. Second of all, whenever we transfer a patient from one hospital within the network to another, we want that care to be seamless. So that's another goal of the care of our patient. And the third goal is to improve quality indicators to enhance patient care. So we look at our hospital-acquired complications, we look at our patient safety indicators. And so what we decided as an orthopedic quality project is to really look deep into PSI, or Patient Safety Indicator 12. What we did to do this is we looked at our internal benchmarking within our network, and we found that within our Orthopedic Institute, we had a higher than average rate of VTEs. When we also looked at the literature over the past 2 years, we found that there were 1,000 papers published that were peer-reviewed on this topic. So it was a hot topic at the time. If you looked at the literature several years ago, like 7 or 8, you would have found not a lot of articles at that time. Also, we keep in mind that VTE can happen to all of our patients in the hospital. However, it has been shown, and there are recognized patterns of high risk. For instance, surgical patients have a higher risk than medical. Patients have a strong risk if they have a hip or knee arthroplasty done, as compared to somebody who is immobile for 3 days at a lower or weak risk. And that there are many different risk assessment scores out there, with one of the best known and one of the widely published being a Caprini Risk VTE Assessment Score. Joseph Caprini did publish that originally in 1991, and there has been over 14,000 articles written about this scale and how wonderful it predicts VTE for our patients. And so, in our future goals, we are going to be looking at that scale. So why do we really care about preventing VTEs? Well, there's numerous reasons right here. The first one is that it's very common, and even though we may not see them in the hospital or they may not come back to our hospital, that 9,000 cases per year in the United States do occur during hospitalization and even post-hospitalization, that they are deadly. 25% of all these patients die of a blood clot to the lung, that they are preventable. With the right mechanical and chemical prophylaxis, you can reduce 70% of all VTEs, that there are complications, and the most common one is known as your post-thrombotic syndrome, which can occur in an extremity after a DVT. What happens is that the vein is injured, or the valve is injured within that vein, and so the patients have swelling, and they also have pain in that area, which is chronic. It can be recurrent. For those that have already had a previous DVT, within 5 years, if they're hospitalized again, they have a 10 to 30% rate of developing another, and they're costly. Overall, it is estimated that hospital costs are $5 billion per year. So prevention is really what we need to be doing. And pre-existing health conditions, we know that those patients, especially a very common example is those with malignancies, they are 3 times at risk for having VTE. So this is just one of the scales. This is actually the Caprini scale. I'm sorry it's so little there, but you can just Google Caprini VTE assessment score, and that will come up. This is a page that a patient can even fill out rather than, a physician or physician's assistants. So when we took a look at our problem with VTEs, we had to first look at the evidence. We had to find it. We had to find out what our root cause was that we could hopefully improve upon reducing the incidence of VTE. So the first thing we did was assign a VTE orthopedic quality team. And that was an orthopedic attending who facilitated our group and led us onward. An orthopedic resident was also involved in this quality project and had a real strong belief in prevention of DVTs. We did have a health outcomes researcher that whenever we gathered the data made sense of it for us. And then of course there was me, the advanced practice quality nurse. I was involved too. We decided at first that, with any research that you do or any study that you want to have done, you have to look at the point prevalence. You have to look at a period of time. And so our resident did morning rounds 4 times over a 2-week period. And it was a random observation. He looked for compliance to the SEDs and elastic stockings, as was the order physician. And also we looked at our compliance to anticoagulation. We did have an internal report that we looked at. Once he was done with that, he handed those off to me, and I took a look in deeper dive into the medical record to find the documentation, the nursing documentation of SEDs and elastic stockings. So when you look at this, it's pretty sad. Our results of our point prevalence study showed our compression stockings to be 47% compliance when we took a look at that period of time. Our SEDs were 59%. And you might say, well, geez, they're very low. Yeah, they are, but there was room to grow. Also, what I want to point out is that on our orthopedic floor, which is where we did this pilot study, you'll see to the left that there's a lot of subspecialties. And so we were concerned with, well, was it best practice for that subspecialty to order anticoagulation or SCDs and elastic stockings? So keep that thought in mind. When we looked at our results for chemical prophylaxis compliance, we seen that to be a 54%. And you'll see that I did block off the names because, that's for HIPAA prevention. So that's 54%. And again, you can see that, we had a lot of room for improvement. So when we took a look at the subspecialties, we decided that we had to get the physician perspective. And there were 3 little sub-items there we had to look at. First of all, we did send out a VTE survey to the subspecialties. We did look at our physician orders to be sure that were they ordering from the right order set, the right orders. And we took a look at the physician daily documentation. So going to the subspecialty VTE survey, we found that there was really a lack of consensus among the doctors in that subspecialty, which would be how they would treat it and what they would order for DVT prophylaxis. There was guidelines that did exist. That was certainly apparent. However, their concern was that each patient was looked at individually for their condition and their physician clinical judgment. And so that would just prevail over any guideline that they would have. Second, we looked at the physician orders. I took a look, 2 weeks worth of hip and knee joint replacement order sets to be sure that they were ordering the appropriate VTE prophylaxis, and they were 100% compliant. And I do have to tell you that with these order sets, I talk with the residents all the time and we update them. So this 100% compliant was not surprising to me. They wanted to develop an order set that was usable, and they are using it. And then the physician daily documentation. What was noted in their note, they had a formatted note, and it would just say, yes, the patient was ordered the anticoagulation and SCDs. However, when a patient refused that, or they didn't take their anticoagulation, that was not noted within their documentation. So another perspective we had to look at was the nursing perspective, and we went up and we did a random survey with all the nurses one day from all units of our hospital. The first survey question was, why do patients refuse SCDs? Why? And some of the most common responses were the patient said that they were too hot. They make my legs sweat. they are too hard and they are uncomfortable. So we kept that in the back of our mind because we did take a look at our SCDs, what we were using, and we had the clear plastic ones at that time. Our second survey question was, why do patients refuse anticoagulation? Well, they don't want an injection if they have, the sub-Q heparin. They just took their Plavix, which then tells me that there really is a teaching moment there to be done. And then that they didn't like getting an injection at 2 a.m. in the morning, and unfortunately in the electronic medical record world, you do have to change that time. And some of them just do not want the medication. But again, what we found here is that the nurses did not report that upward. They documented it, but they did not report that upward. So here's what we did with the SCD sleeves. We went ahead and we took a look at the companies, and we decided that we would go ahead and pilot these cooling or comfort sleeves is what they're called. And we did do a 2-week pilot in our system and found that over 100% of our patients said that, yes, they're comfortable. They kept them on longer. The nurses liked them because they were more pliable to the leg. And as you can see, they're a material, and also you can see that they have holes in them to let that heat dissipate. So we're hoping to get these next month. And then lastly, we had to take a look at the patient perspective. How are patients taught about VTEs, or are they taught? Do they remember what they're taught? And what we found is when we asked lots of different departments and our pre-op areas that there really wasn't a consistent practice. Our pre-op process is not mandatory. Some of the surgical areas do have classes that they offer the patients. They can do them in person, they can do them online, but again, these are not mandatory to look at or to review or to attend. And again, whenever we took a look at the physicians' offices and asked them, they said, well, yeah, I gave them the handbook to read. Yes, I did teach them, that they probably don't remember, or they just didn't have time. It was too busy of a day. And I'm sure that is generalized throughout all of our hospitals nowadays. And so whenever we take a look at the patient perspective, we thought, well, geez, could we do a handout, or was it better to do a poster? So keep that in mind as I move on. So our outcomes of our project at this time, or at the time of all these point prevalences, was that despite all of the best practice guidelines for the physician and subspecialties, really they determine what needs to be ordered for the patient. So we have to rely on that order from them. Second of all, we needed to develop a consistent process for VTE mechanical and chemical compliance. So does that mean we have to do a guideline? Do we have to do a policy? And we did research best practices. We did look at 166 articles, of which we then, whenever we took a look at the specifics for the barriers and for nursing care, there was probably 36 that were identified. And what we did is we took the best out of all of these articles to really do a pilot on our best practice. We did achieve system approval, and with all kind of nursing education and continued nursing education, we have made our policy pretty much a nice guideline to follow, and something that really covers the nurse with documentation. And then third of all, we did develop a specific and consistent practice to teach the patient. We developed a VTE poster, and this was widely accepted through our Nursing Professional Practice Council. They said, oh my gosh, that's great. We don't have to hand somebody a piece of paper that will just go into the trash basket. So we developed this poster, and again, those are just widely used posters, and we'll show you that in a bit. So the highlights of our AHN VTE policy is that, first of all, you have to rely on the MD order for chemical and mechanical prophylaxis. That goes without saying. Second of all, they have to be worn at least 18 out of 24 hours for that lytolytic action to take place. Just the squeezing and the compression of that SCD helps to prevent clot buildup. And then we want the patient to be able to wear them in the chair. And the reason for that is, nurses will say to me, oh, yes, they're ambulating. Well, how are they ambulating? To the chair and back to the bed. And really, that's not ambulation. Ambulation is out in the hallway walking. And so what we said to the nurses is that, just them going from the bathroom or to the bed to the chair is not enough. And that's why they need their SCDs. There is, some concern about falls, but we will monitor that. But some of the literature states that with SCDs in the chair, their call bell within reach, the nurse is doing hourly rounds, that falls really have been very, very uncommon. So we are monitoring that. If the patient refuses, now the nurses have sort of like a ladder. They have to reteach, and then they have to notify the physician whether or not, and we said, yeah, you can page them if you want, you can go ahead and text them if you want, but certainly they can, address this on rounds, which is really the better option. That mechanical and chemical prophylaxis cannot be held as a nursing judgment. So, this really prevents a gray area, because some of the times the nurse will say, well, nursing judgment, I didn't give it because the patient's going to the OR. And sometimes, depending upon the class of patient, like traumas and neurosurgery, if the patient is stable beforehand, a lot of times they go ahead and they give that Lovenox before surgery. But again, don't hold it. Call the resident and ask, should I give it or not give it? That's really the best practice. And right now we're revising, because we did want to add a contraindications column, not only to the policy, but also to our electronic documentation record. So here's our Stop the Clot teaching poster. You can see that this comes from the Blood Clot Alliance. They do share all of their posters and teaching tools that you can use. And so, giving them some reference here in case you want to use it. And what we did is we put that in our rooms. I'll show you in a bit where that's at. But we put it on never tear paper so that infection control preventionists do not have to worry about, that being an area where, bacteria can accumulate, because it can be wiped down, by our housekeeping staff. And then, of course, our teaching posters right under the TV. Now, you're going to say, oh, that looks a little small. And that's probably what one of the uncommon complaints have been, is that's a little small. They would like it larger, which we're in the process of doing. But it is colorful. The red and the blue bring it out. And out of 144 surveys, which I did, everyone liked it. They loved it because it was colorful, it was noticeable. When the patient's families walked by, they read it. They can take pictures of it on their iPhones, and there are references there too that they can read. Out of 144 patients, there was 144 that loved it. And the family members got involved too with this, because they have known, as well as the patient, family members or friends or neighbors that have had blood clots. And so, the public is very well aware of this issue. We also had several patients who had AV experiences and in poster development, and said to us, you know what, that is like as soon as I came in, I seen that poster and I'm like, whoa, that is like really cool. But it was really the nursing staff who decided where to put it in the room, and they can point to it and teach, as well as our attendings, our residents. And so it's not a piece of paper, it's there all the time that they can read. So we really like it, and we've gotten some really great responses with it. So what is overall our compliance of this prophylaxis, and mechanical and mechanical? So what I did is I graphed what our compliance rate were, when you seen the first graph at the beginning of time, which was really at the end of 2019, beginning of 2020. And you can see that, we were really bad. And you can see that in the middle, which is in June and July, that we did increase. And at present time, and this is really February 2020 data, as you can see, we're above the 90% mark in both SCD and anticoagulation compliance. We really believe that, we continue to monitor, we continue to create awareness, and we have achieved our outcomes, and we would really like to inch up higher. But again, over the past year and with the challenges that we have all faced, I consider this, a great win. So what are our next steps? Well, first of all, we need to complete the policy revisions and also our electronic revisions so that the nurses can document when there is a substantial and literature-reviewed contraindication that supports the nurse to do this. Second of all, as I said, we need to continue to comply, to continue to monitor the compliance and to continue to create awareness. We have new nurses starting, we have, nurses everywhere starting, so we have to always continue to teach. We need to continue spreading the word with our posters too, so that they are in other areas of the hospital. And ongoing huddle and nursing education. We post some of our outcomes on the nursing unit so that they know and they're aware that every action that they've done, they have shown a great compliance, and, good for them. And then formally implement a pre-surgical Caprini VTE assessment score screening. We really want to do that in our institution, and we have felt that with all of our research, we're in the process of looking at that. So that is all that I have, and that I appreciate your attention, and thank you very much.